Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. Today, we are at episode 125. That's pretty exciting for me. Over 113,000 downloads, so I appreciate the listeners out there. And even more than that, I appreciate you telling me where you listen to your CodeCast. I've heard in the shower and while cooking, while driving is the most popular. I have heard some really funny stories on where you listen to it. I hear it piped into some medical facilities. When I walked into a couple of places, hospitals, I can hear myself on the recorder or I guess on the audio, which has been just a great compliment. So I appreciate all that. So today, the CodeCast is also brought to you by Keck Medicine of USC, over 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, Los Angeles, California. So my topic today was actually put together from, I hate to say frustration because I don't want to start off negative, but I guess my realization that most billing offices are really attacking their insurance claim denials instead of having a plan. So I have been seeing a lot of this with existing clients and some new clients that have just come on. And now, when I look at how they handle these denials, I feel like it's time to give you a new approach, and an approach to this in which can not only help you be successful in the entire revenue cycle management process, and that means from the time the patient comes in and gives you their information, demographics, and insurance card, all the way to the end when they have a zero balance. But it's also really important for me to have you be methodical in your workflows and your processes when trying to resolve denials, or you'll just be spinning your wheels and you'll get as frustrated as I can get when I kind of see some of the ways people are trying to figure it out. So this is going to be a very detail-oriented podcast. And so for those of you listening in the car or listening on a place where you actually aren't able to take notes, I would consider listening through it all, kind of, contemplating or pondering the information. And then you may want to go back and take some notes because there's some information that I think could help you if you write it down. I also, I teach a lot of webinars, as you know, and teleconferences and digital platform educational workshops. And one of the things that I love teaching is collection appeals and denials processes. And so if you want to get even further into this, again, look at my website because we've got webinars that give you great material, appeals letters, and things that can help you in your process. But we do charge for those. I know some of you have said, we hear you have a couple of webinars coming out. When are you doing it for free? Okay, so just a kind of a understanding of that. I know there's a lot of free webinars out there, and occasionally I'll do one that's maybe 10 minutes or 15 minutes, or for another society as part of a membership process. But this is our business. This is how we generate our revenue, is by giving you educational services. Then obviously you get what you pay for. But the podcast is what you get for free. So for right now, they're not charging for podcasting, but I am hearing that could change in very soon because and if you listen on Spotify, which this also is on that platform, you're paying a membership fee. But a lot of people are asking for contributions to Patreon, which I've considered that and giving some extra episodes. But for right now, I want it to be available to people, when you can just sign in and get it and download it without cost. But to move on from that to a educational piece, that's when we get into charging you for services, because this is what I do. So just wanted to kind of put that out there because I have had some comments or questions on people wanting everything for free, and let's be a little bit fair about that. Okay, so we're going to dive deeper into denials today and really look what healthcare professionals can do to draw on maybe the power of some analytics to improve your processes. And, claim denials are really a sore spot for all kinds of healthcare coders and providers and professionals because you strive to improve your revenue cycle. And it's hard to do that because there was a study in 2017 by Change Healthcare, and they found that $262 billion out of $3 trillion submitted by the medical claims industry were denied for U.S. hospitals, and $550 billion by physicians were denied. So there is a lot of information out there that you're basically sending in a claim and you have no shot of getting paid. And so we want to see why that is, not only on the back end, but on the front end. And I've noticed that for years, healthcare providers and again, the billing office, coding office, have tried to resolve denials on a case-by-case basis or even by individual payers through various means such as bulk appeals and individual claim rebills and appeals. But there's been a little bit of a lack of a dedicated focus on the reason for denials and how to approach these opportunities for a meaningful and positive impact to your practice and your organization. So manual processes that have defined revenue cycle management over the past 10 years and longer have limited the healthcare organization's ability to actually get a bird's eye view of claim denial trends. But with the emergence of analytics and underlying technology, that actually has changed. So now it's easier to handle large data sets and the right combination of this data, plus the right people in place, and hopefully, experts like myself in the revenue cycle process can enable you to significantly reduce some of these denial rates. So if you're a coder, biller, charge audit validator, collector, whatever your revenue cycle management title is, and you're in charge of attacking denials, you need to first take the data elements from the explanation of benefits, and I'm going to refer to that as the EOB. This will help you identify trends in specific departments. So for example, you can run reports that identify different types of denials. You need medical necessity denial, authorizations, coordination of benefits. And remember what that means is that is when you have the patient has two insurances, but one is primary and one is secondary. And you want to use that information to pinpoint the root cause, then set up a work group that includes key stakeholders from each department, so people that are in charge in each department, to work through ways to prevent future denials. Starting on the front end of the revenue cycle management, that's how you can prevent denials, and that's sometimes overlooked on the front end or minimized, because I've heard people say, well, we don't have time to do that. All we have time to do is attack what's on the back end. And then I'm reviewing an accounts receivable that 80% of their charges are in 120 days or beyond, and once you get past a certain time frame, it's almost impossible to collect. So beyond process flow opportunities, denial analytics can further pinpoint non-financial viable line items, clinical treatment pathways or plans, and maybe they need to be enhanced, clinical criteria that hasn't been considered before, payer guidelines standardization, pointing out that the insights that come from denials impact every single touch point of both the patient care and the revenue cycle continuum. So that's why you need, when I call, say, stakeholder from each department, that's somebody, even if they're not a collector, a biller, or a coder, maybe you have a back office staff and you can ask them about, how they're handling their waivers and ABNs for patients and how they're pulling some of their diagnoses. Is it based on just what they're coming in for chronically, or is it based on what the need is for that specific test or lab or procedure that's being scheduled that day? So you need to have somebody from each department. Also, analytics are ensuring a more holistic approach to the denials because they allow for specific key performance indicators and certain metrics to address the denial trends. And we have to look at it by priority and categorization in more of a real-time approach versus being handled retrospectively in the claim billing and in the claims resolution aspect. You don't always want to have to attack a denial. You want to see if you can basically stop a denial before it even leaves the building. So let's talk about this, for example, when we look at some of the acronyms and the impact of what we call CARCs and RARCs. So what this is, when we look at CARCs first, and that's where the acronym is Claim Adjustment Reason Code. This describes the primary reason for the denial, while the RARC, or Remittance Advice Remark Code, they help clarify the denial, so the why. So consequently, both codes are critical to properly analyzing a denial. CARCs are used on an EOB to communicate the reason for payment adjustment that describes why a claim or a line item on a claim was paid differently than it was billed or denied altogether. And it's important to understand that each insurance payer may use these codes in different ways. So specifically, CARCs or use a 2-letter prefix in addition to the number to communicate. So they're used to assign responsibility for the adjustment amounts, and they use 2-letter group codes. Okay, so for example, CO, contractual obligation. CR would be corrections and reversal note. So this value is not to be used with 005010 and higher. OA, so that means other adjustment. PI, that means a payer-initiated reduction. So that could be something internal within the contract. And PR, patient responsibility. So for example, CO45, that's a contractual obligation. So that indicates that this is a contractual obligation in which the charge billed exceeds the fee schedule maximum allowable or contracted legislated fee. This means that there's a set or allowed price that the carrier will pay for these services being billed. The difference between the amount billed and the amount allowed is an amount that is not paid and must be adjusted. Okay, so you have a billed amount, an allowed amount, and that's the adjustment, and then you have the paid amount. In contrast to the RARC, so again, revisiting that is the Remittance Advice Remark Code, which is clarifying the denial. This is used to provide additional explanation for an adjustment already described by the CARC, or to convey information about remittance processing. So for example, you might get an M20 on an RARC, and that refers to missing, incomplete, or invalid HCPCS code. So CARCs and RARCs, they provide kind of a gateway to identifying and understanding trends, patterns, volume, and the dollar value for the denials. So these codes will allow a provider or healthcare entity to categorize the reasons the payers have either not adjudicated a claim at all or incorrectly adjudicated a claim. And so conversely, such denials may be accurate and correct from the payer, and identifying key process failures, noncompliance with payer guidelines, or gaps in the clinical care guidelines, even medical necessity criteria that support the level of care being rendered. So that's why you use them in conjunction. And so that's why you need proper and detailed reviews of CARCs and RARCs, because these can provide a window into the areas where providers have an opportunity to enhance processes and minimize future denials. And this model provides a different approach than traditional methods of just seeking resolution at the individual claim denial level. And that could result in proper payment of the claim in question, but it doesn't result in an overall reduction in denials at the payer level, or more importantly, at your practice level, again, before it leaves the building. So performing a deep dive is what we call it, analytics review of the codes, will result in an understanding of payer expectations for various claim and service types. So why the net revenue and cash flow for a specific payer is not at the expected level. And then it also can identify the departments and processes that are resulting in these routine denials. Again, why you need a stakeholder from every department. Because I'll ask practices when I go in and I'm looking at their RCM, or, I'm getting on for my membership, my Coding Corner membership, I'll get somebody say, can you help with this denial? And I've noticed, especially for clients that I've had for, 20 years, I'm getting the same denials. And I said, do you have a list of these? Because I've seen these come from you before several times. They said, a list? What do you mean? We just attack denials as they come in. So that's where you really have to start keeping track. And this is why we call this analytics and information that you can really get digitally now. So understanding the difference between the reason code, the issue, and the root cause is also going to be important. So let me try to differentiate it for you. So the reason code, issue, and root cause, look at it this way. CARC, or the reason code, is the information provided by the payer for the denial. The issue refers to the prima facie grounds for the denial, and the issue in most cases is on the provider side, but could occur on the payer side as well. Finally, the root cause refers to the buried issue or the process where the cause for the denial originated from, and that's going to come from your office. And I'm talking about your central billing office and where the denial originated from. So with these three elements in play, again, you're looking at reason code, issue, and root cause. Your healthcare organization can have the necessary data at their disposal to create a corrective action plan and provide feedback to executive management and, again, key stakeholders, so people that are in charge of certain departments within your operations. And the analysis will also uncover processes and procedures that may need to be created or revised in order to ensure details and are prevented moving forward. So an example, this will be, and hopefully if they're listening to this podcast, they're not going to get mad at me. They're going to know who this is. I have a podiatric client and I love them. They're a great office, but they're getting inundated with appeals right now and requests for pre and post payment. And one denial, which denied strapping and casting and an Uniboot charge, as denied with an E&M service, and it said due to NCCI edits. Well, that was not an accurate statement by the payer and not accurate in the way the biller handled the appeal as well. So a lot of problems here. So the biller tried to appeal, saying she looked at MUEs, which we know are medically unlikely edits, how many certain line items you can have per day for one patient by the same provider, and said, we disagree because the MUE said we can have multiple codes per day. Well, that wasn't what the denied claim was for. So that response will make no sense to the payer from a denial perspective. The payer also said they use NCCI edits, mainly because a 59 modifier was used incorrectly on a claim. But what they should have said is that we deny codes that reflect parenthetical inclusiveness per CPT. So I would agree with them that the strapping was included in the Uniboot charge, but they denied both. So when we appeal, we explain that to them. Also, the E&M should have been paid. And in my appeal, I rewrote for them. I reflected that based on the presenting encounter information. And you have to understand what you are appealing, what the denial actually is for. Otherwise, you are spinning your wheels, and you don't want to do that. You work hard enough on things you can actually control. So when you get to the denial situation, you want to make sure that you are, I hate to call it reading between the lines, but that you're clear on the details of what the denial is for. Capturing these items within the analytics initiative allows the hierarchy and the drill down necessary to resolve the accounts in question. So identify multiple trends as by physician, department, procedure, or service line, then end user and payer and charge codes, those are big, and identify and address the processes and procedures that could be leading to such trends. The one thing that actually really bothered me about this denial and how it was handled on both sides of the aisle, both with the payer and with the biller, was the fact that they didn't first address the problem. They didn't look at CPT and say, oh, these two services, the strapping and casting and the Uniboot, would be bundled together. It was clear, don't code this code with this code. But then the fact that they just take the word for it from the payer saying that this is a CCI edit denial, and it wasn't. And so you have to really understand not only the definitions, but understand what the payer's mindset is when they're sending you information, because you're going to have to be on top of it and almost, I hate to say be smarter than they are, but from a billing perspective, you are. Another example, let's say, for denial would be for no authorization. That's a denial reason code N39. It says services denied at the time authorization pre-certification was requested. So the issue is that proper authorization was not obtained on the case. The root cause may be that the front-end processes in place for obtaining authorization do not have a mechanism to reschedule or cancel services until an authorization is confirmed. But having all three elements in a comprehensive analysis would be crucial for there to be a change for long-term positive effects, because without those three areas, you're going to still have repeated denials and individual claims resolution on the back end. So understanding that as well. Another example would be for a procedure that is denied for being deemed not medically necessary. I hate those. The initial issue could be that the coder missed recording a diagnosis code, or that the underlying diagnosis data in the medical record was unavailable. But in either case, the root cause signals a need for improved education and documentation for both the provider who's documenting the diagnosis codes and the services, and possibly the coder who's inputting the information and linking the services. So the amount and type of data available will also dictate the level of analysis that can be performed. I'm noticing when I see denial codes 837 and 835, those are the most relevant in an initial denial analysis. If 837 and 835 files are not available, all the data elements reflected on the claim form, along with the detail of the remittance advices on the EOB, those are necessary to look at these analysis. So initial findings and trends may necessitate the need for further information from the clinical documentation that's in your EMR. So ideally, the demographic, medical insurance, financial data for all claims, both denied and paid, are captured to perform the best possible analysis. So you need both scenarios. Some of the rare denial scenarios could be based on place of service, patient's gender, the patient's relationship with the subscriber, the frequency of a service. Frequency guidelines are huge within a certain time period, or the provider acceptance to assignment of benefits, or if it is a contract provider or not. But if all these fields are available in the database, then you need to make sure you're running reports for that analysis. The most necessary data elements are the following. First of all, CPT codes, then revenue codes, then CARCs and RARCs, then the bill type, expected reimbursement, payment, quantity billed, modifiers, payer, and then account numbers. The key thing to remember is that a comprehensive denial management plan, it's not one and done. This is ongoing analysis that needs to be performed. And although as much as automation can help, people and manual processes are at the heart of this process. All of the automation in the world won't fix somebody who's not properly trained on how to handle denials. So a first step, I would summarize denials in a manner that clearly identifies where there is the most opportunity and financial ramifications. What are your top 3 denial codes? What payer? This will reflect which denial reason code or category needs prioritization in the development of your action plan. Likely some denial categories may be as simple as an overview with the staff, or maybe a system tweak of what's not pulling from your electronic health record. The next step entails securing the current policies, procedures, and protocols associated with the root cause to identify where there's gaps in your process. So the root cause will also need to identify end users, the clinical team members who are in the system, and everybody contributes to that claim being successfully paid. Physicians, providers, mid-levels, back office staff, and anyone else associated with the denial to further determine trending by individuals to address training needs if the protocols and procedures are appropriately aligned to prevent denials in the future. And then an action plan must outline how existing denied cases will be handled and by whom, how their successful resolution will be measured and tracked, and how resolvable denials will be handled and accounted for. And probably most importantly, what actions will be taken to prevent future denials in this category. Again, the biggest thing I see is when somebody is not trained on how to handle denial. One of the things that I've gleaned over the last, 31 years in the industry is that I can look at a claim and I can tell you within 10 seconds what's wrong with it. You need to have people that are very similar to that to say, okay, let me see what's wrong with it. Perfect example. You see that a patient had a joint injection, 20610, and then you notice that the E&M service was denied because somebody put a 57 modifier on it. Well, if you know anything about modifiers and global days and billing, you know that that was the incorrect modifier. It should have been a 25. Also, you have to look at the diagnosis. Was the correct diagnosis linked to the line item 1 and line item 2? I see a lot of staff and coders and billers and, again, the collectors will just rebill it and say, you need to pay us, instead of addressing the problem. So when you look at these denials, you need to know what performance indicators and understand that category so that your action plan can also help train and for your staff to understand some of these denial categories. So I hope you found that information helpful. I am coming out with a book within the next 30 days on just how to tackle insurance denials. It'll be an e-publication, so you can get it on my website, but just really being methodical and showing you how to do this. Obviously, we always have webinar training on this, not just denials, but a collection and appeals, and giving you tangible tools so that you can really make this more of a reality. But most of my practices that have attended these workshops and followed these denial actionable recommendations. They said they've increased their collections at least 20% within the first 6 to 8 months. So we want you to make sure that you're not losing revenue right now, especially in the political climate and in the year we're in. We want to make sure that you know what's going on and how your money could be affected coming up. Okay, so I want to get to my coding question, and I know that we are already close to my time frame for my podcast, but I think that it is important that we take this question because of the coronavirus. It's all over the news, as you know, and so I really need to deal with this question. It might be a little bit longer than what you're used to. So it says, "Hi, Terry, I have a question on the coronavirus. It's all over the news, and I'm so lost in my ICD-10 diagnosis coding. Can you help before I lose my mind?" Okay, so let me just give you a tidbit. I am going to have an updated ICD-10 webinar on April 16th, so make sure you check my website, because you also have some new vaping codes, and there's been some latest guidelines that you really want to get updated for. But here's what's happened. So the World Health Organization has declared it to be a public health emergency. It's not a pandemic, but it has an international concern. And according to the CDC, which is Centers for Disease Control and Prevention, the virus has been named SARS-CoV-2, and the disease it causes has been officially named Coronavirus Disease 2019, meaning COVID-19. Now, because it has been declared a public health emergency, the WHO created the emergency ICD-10 code to identify this. Now, remember, they create it, but they can't use it, or it doesn't become effective until October 1st, 2020. And that would be the U07.1 code. And that's going to be implemented again October 1st, 2020. But what do you use in the meantime as you have confirmed cases related to COVID-19? So pneumonia due to the COVID-19, that would be J12.89, other viral pneumonia, and B97.29, other coronavirus, as the cause of diseases classified elsewhere. Acute bronchitis due to COVID-19, that's J20.8 and B97.29. Bronchitis not otherwise specified due to COVID-19, J40 and B97.29, and these are the ICD-10 codes. And then we have lower respiratory infection, not otherwise specified, or acute respiratory infection due to COVID-19, J22 and B97.29, so they go back up to that bronchial infection. For possible exposure to COVID-19 that is ruled out after evaluation, this is an important one. I think this is being used quite a bit. That would be the Z03.818. And then you'll also need, and this is called encounter for observation for suspected exposure to other biological agents ruled out. If it was a patient that was exposed to someone with a confirmed case, you code assign Z20.828. And then if the patient just comes in with a sign or symptom and you have not established a definitive diagnosis, means you have to have a confirmed lab test. So they're just coming in with a cough, RO5, or shortness of breath, RO6.02, or an unspecified fever, R50.9. It would not be appropriate to code the B34.2 coronavirus infection unspecified. Don't do that. That is respiratory in nature, and you have to make sure that your doctor isn't saying possible, probable, suspected. You need the sign or symptoms that present for exposure to the virus. And so just make sure you're not over-coding that, because it can give a false positive on how many cases we actually have out there. It's not a pandemic yet, so that we're not quarantined to our house, even though there are some self-quarantine people doing that came back from Italy, that are coming in and out of China, which we know we've had some travel sanctions put on that. But just make sure you're trying to code accurately and not assumptive coding. Please don't do that. That could be a problem. Okay, so last thing My personal insight, hope this helps you. This is what's for dinner. So somebody asked me the other day, hey, Terry, what do you usually make for dinner since you work such long hours? Well, there's a trick I learned years ago. I take an hour on Sunday and I make a pan of taco meat, shredded rotisserie chicken, and I put them in my sealed Tupperware containers. And then I always, staples in my house, a bag of shredded cheese, hot sauce, tortillas, a jug of spicy salsa, and of course, some tortilla strips. And you can have tacos all week. And, also one thing that's always in my cupboard would be spicy refried beans. So they're always there and it's super cheap for those of you who are on a budget. You can have tacos or burritos for the week. It lasts up to, 7, 8, 9 days. They last forever. Tortillas last 3 weeks, and it's just so cost effective. Also, people drop by my house all the time and they're like, hey, got anything for tacos? They know the answer. So I'm not saying I don't love a nice restaurant. I'm sure I've mentioned them on here before. But if you're someone that just needs to get home, not deal with the grocery store during the week, try it. It's so worth it. It'll save you money. And the reason I do the salsa is because I can't always get like a fresh avocado or tomatoes or anything like that. But I still want to get some veggies on my, and I also have canned jalapenos. I'm a jalapeno-aholic, or jarred, I should say. So I always have those as well. So hopefully that helped and answered a question. And hopefully that's what's for dinner for you. But thanks everyone for listening today. I know I had a lot to discuss and we went a little bit over our 30-minute time frame, but I hope you found it useful. And a reminder, you leave us a rating and a review in Apple Podcasts, YouTube, Stitcher, or wherever platform you listen to the CodeCast. We would greatly appreciate it. Our coding question was brought to you today by Stratus Building Solutions. Stratus Building Solutions is leading the way in health and environmentally conscious commercial cleaning services. Green Clean chemicals, Green Clean certified, biodegradable, non-toxic chemicals, providing a healthier environment for your customers, your patients, and employees. Protect your practice today. Stratus Building Solutions.com. So on this Terry Tuesday, everyone make it a great day, a great week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.